Hey folks, we're back. I'm your host BKP. We're at Circuit World here in Blue Ridge, Georgia. We've got the Christmas tree right over there, and they look like they have plenty of TVs here still to go out. But it's time for Ask the Doc with Dr. William Whaley and Dr. Raymond Tidman, and we thank Georgia Cancer Specialist, Northside Cancer Center for our segment. How you doing today, guys? You doing well?
Very good.
All right, I'm going to start with you just commented on this jacket.
Yeah, I like
So
that.
I got to tell you about Dr. Tidman and I last Saturday evening
Oh.
in Blue Ridge, Georgia. There was
Did he clear this story with you?
There-
'Cause
no,
he's
I
No,
didn't.
I'm about to get in trouble here.
there was a what was an event at 5:30. There was a parade.
yes, a parade.
Okay, and if you looked at the newspaper or saw stuff, I drove my truck, right?
Yes.
Okay, in the back of my truck were 4 bales of hay and 6 kids and 10,000 pounds of candy that they threw out and everything.
I saw some pictures.
Okay, so the next morning after church, I had 4 bales of hay, right? So I put on my gloves and my boots and my Blue Ridge, Georgia lumberjack
I'm
stuff.
warm this
and
morning.
I drove out to this farm, people, friends of Jane's that have these cows, and then we broke up the hay and we threw it over the wall and we fed it to the cows. And then I drove my old red pickup truck around. And what I'm trying to say is, this is small town America at its best. There were thousands of people lining the street, had a really good time. We got together after, right? And the city looked real good, and we ended up feeding cows. I mean, how much better can you say small town America than that?
Well, it was really quite a beautiful scene because you had Christmas lights everywhere, lots of people walking around smiling, and it was just
you
really
you
pleasant.
can't see that in the city.
No, but at first, see, I thought you were going to say that was your Kevin Costner look
Oh, no.
from Yellowstone. You've been, you got
Yeah,
your...
right. Well, Jane loves that guy. She thinks he's
Yeah,
good.
so-
Anyway, but we had small town America at its best last
Yeah.
week, and you talked. So this was.
I agree
this is
with you.
jacket
I agree
wore
with
to-
you.
this
All
jacket
of
I wore
the
to
all of the events
feed
and
the cows.
Blue Ridge is right top notch. All the events in North Georgia, from Ellijay, Blue Ridge on up through Union and Blairsville, all of them are just absolutely great. And it's small town
It's
America,
small
rural
town America
America,
at its best.
and it is the Christmas atmosphere. That if you want your family, this is Ask the Doc, but if you want your family to get the real Christmas atmosphere and a Christmas feeling, come to Blue Ridge,
You won't
Georgia.
believe how many people there
Absolutely.
were there. And as I would ride through, and the kids would throw the candy, and everybody was taking pictures of the truck. They love the truck. I would just say, when you get back to Florida, wherever it is, tell them you saw small town America at its
Always
best.
remember the upside. When you're throwing stuff out at them, just as long as they're not throwing it back. Sorry, I don't know where.
All right, we're supposed to ask
I've been
questions.
sitting on that one for a while.
All right, I'm taking the baton back. I could have asked this question. Ray could have asked this question because it begins with this. I'm confused. No, that's the part.
No, that was the part of the question I understood.
All right, I am 75 years old, blonde and fair-skinned. Now, that's both of us. Raised on a farm in North Georgia. Well, I was raised in the sun, but not a farm. And I have had sun-related skin cancers for 40 years. At first, they were cut off and sutured and left scars.
Okay.
For the next 20 years, I had Mohs surgery. Now, we've talked about that before, and you'll see it. We're not going to show it today. The last 3 were locally treated in the dermatologist's office with superficial radiation therapy, which worked great. Now, this is a question about superficial radiation therapy, which we're going to talk about in a minute. It took several visits, but I liked this treatment better than Mohs surgery. So this is the evolution of skin cancer treatment over 40 years. So first they used to cut it out, and I got a big scar right there.
Yeah.
We've talked before about the Mohs surgery I had up here where you don't see a scar except that my eyebrow skin's up there, and periodically I have to pick eyebrows out of my forehead. But it made a scar, but they buried it in a wrinkle. And this new treatment, this superficial radiation, doesn't leave you with a scar at all if you're up to it. So this guy just tells us in his introduction about the history of skin cancer treatment, right? This is for not melanoma. We'll come back to that in a minute. All right. Now, my wife has a whole chest full of skin metastasis from her prior breast cancer, which you discussed in a question about hormone therapy last year. So I went back and looked, and yes, we did have, I know who this patient is, who had metastatic hormone-positive cancer of the breast on hormone therapy and had some early skin metastases there, and he wanted to know should they be removed. And I said no, and she was on hormones and was had good control. Now this is a year later, so these skin metastases are growing. And you discussed a question about the control with last year. Oncologist says now her disease in the bones and lungs, which she had at that time, remains in good control with hormones. And he wants her to go to a radiation oncologist for superficial radiation therapy, and says the local dermatologist cannot do it. Why not? Well, that's a pretty decent question.
That is a good question.
All right, because both of them, it's like a rose by any other name. You know, the superficial radiation is a broad category of radiation therapy, and let's pull up that first slide there. This little machine that you see in this picture here, this is actually sort of important, has a little square. You see that little square? It's probably about as big as a deck of cards.
Right.
Okay, this is a dermatologist superficial radiation machine for his office, okay? But it's like the dentist who has a thing he pulls down to x-ray your teeth. It's a little bitty x-ray here. That wouldn't x-ray your chest, right? Wouldn't x-ray anything except your teeth, and it's small and concentrated. So we pull that one down. So now we got this whole bunch of pictures of skin cancers. Well, these malignant melanomas, these pigmented things over there, they're not appropriate for superficial radiation therapy. But the basal cell and the various types of squamous cells, which are on this left-hand side of these beautiful pictures, you can pull that down now. Those are the ones that are eligible for radiation therapy, and particularly if they're like on the edge of your eyelid or your nose or your ear, you will end up with a better, lip, that's good. Yeah, you don't want your lip looking like that. But you remember, for a while, my eyebrow was up here after that Mohs surgery. It went back down after a while. So here's a couple of these pictures. So here's an ear with a big old, that's a big cancer there. And if you cut that out by any other means, whether it was Mohs surgery or anything else, you'd have a wedge out of that ear, and it would look like that, right? So that's pretty good look, and that's only a month later. So that redness around there is going to go away. And here's another one now that's on the nose that would get, if you took it off, you would be losing a hunk of your nostril even with Mohs surgery. You'd have to have a plastic surgeon move a flap in there, and you'd end up with a deformity. Well, this is 3 months after, and it looks like a regular nose. It's just still a little bit red, and that redness will go away. All right, show that next one.
And that's the radiation therapy.
That's it. That's that little guy.
That's the dermatological.
That's that little bitty thing.
Okay.
Dermatologic. Okay, so now.
That's off that one there.
And this one is too.
And the question is, why can't your dermatologist, your local dermatologist, use that
on this skin cancer?
On the skin, okay.
And
you're good.
On breast
cancer.
Right, okay.
Because remember now, this is just in the skin. All right. So this is a deep. Those were squamous. This is a deep basal cell, and they've made a mark around there of what you would have to remove if you did a surgical procedure. Now that is a big. That's the last day of treatment. That nose is red, bright red, right? That's 30 days later, and you can see it's just about faded out. So it is a much better result than you would have gotten from anything else. And I'm pretty proud that now way up here in the mountains, we've got some dermatologists who have that capacity in their offices, and you do not have to go to Gainesville or Atlanta or Canton to get that treatment.
It comes down to.
Well, you got to pull that one off, right?
It comes down to a regulatory issue. The dermatologist has a device in a machine that's been approved for a certain kind of cancer in a certain location. And if they go outside of that window of what that's approved for, then they're not covered for what they're doing there. And whereas the radiation therapist, he has machinery that's much more intense and much more designed and been around a lot longer that can go after other cancers deeper and more indicated. But the dermatologist would really be setting himself up for suits or
Well,
something.
that's a good way of looking at it. I wasn't even going to mention the fact that he'd be sort of outside of his sandbox, but
right.
and he doesn't. He does use a physicist and a radiation oncologist to do the calculations here.
Mm-hmm.
But when you're talking about real radiation therapy, the reason it takes several weeks to get it started is once they've decided what they need to radiate, they get all these kids from Georgia Tech like Ray, and well, I won't say kids because they're not, but they are radiation physicists, and they all went to Georgia Tech. And then they create this so you can move the patient around so that the radiation therapy, you've seen those where they were focusing on the prostate or something,
Right.
and you don't mess up a tissue. I want you to look at that skin. There ain't any way that little bitty box could get, you see how bad that looks? This is metastatic cancer. Most commonly would be breast, second most common would be lung, that sets itself up in the skin. And when you're taking hormonal therapy for breast cancer, the hormones don't penetrate the skin like they do the lung, the liver, and the bone. And we know from the question that her lung and her liver and her bone are still in good shape. While this skin, I think that when we saw this last year, she had a little line about that big of you can pull that down now.
Is that this case?
No.
Oh, okay.
Now this is
I
a
mean, when you and I
representative
see a
case.
case like that, we're like amazed.
Yeah, but that's in 30 days that can be gone.
Yeah.
All right, so here, this is a PET scan. This is a PET scan showing all this disease in the skin, and this is before they radiate her, and then this is 3 months after the radiation therapy. You can pull, got those pretty pictures up there? All right, you can pull them back down. So anyway, all those beautiful yellow pictures there, that was the skin, hot as a firecracker, that disappeared with radiation. Well, obviously, a thing that's as big as a deck of cards wouldn't do it, would it? So he needs to be able to radiate a thing that's as big as a window pane. Oh, I guess, yeah, one window pane of glass in such a fashion as to not damage everything else around it. So he's got a physicist from Georgia Tech. He's got a much different type of machine. So yes, both of those are superficial radiation, but one's a 22 and the other's a 750 caliber, so to speak. The people up here don't understand gun analogy. Yeah, right,
You
Ray?
know, these really interesting cases are sometimes good teaching elements. I had a patient that he'd had a little cancer taken off his nose, and he had pretty tough skin. He had a lot of scarring from acne and stuff as a child, but his nose was getting more and more flared and more bulbous. And I had him see many different dermatologists and such, and because it was becoming cosmetically really hard for him. And it turned out that he had what are called keloids. Keloids is a scarring, it's an accelerated scarring of the skin after a cutting or any kind of injury. Some young ladies get their ears pierced and they'll end up with a marble of a scar hanging from their ear or such. It's just a one-off thing, but it happens reasonably often. But this fella had a keloid that basically was deforming his whole nose, not a cancer, not anything else. And you know, the surgeon that I sent him to recognized that and dealt with it. You have to deal with it very gently and put steroids in it, you know, as you whittle on it to get it back down to size. But it was a really fascinating case.
More common in African Americans
Yeah.
or people with a Mediterranean genealogy.
Yeah.
And if you form keloids, you form them. And if
Yeah.
you don't, you don't. You don't know until you have a keloid. They do run in families. All right. Got anything else you want to say about the skin?
No.
You sure?
Yeah, I'm pretty sure.
All right. Well, now take a real good look. I don't know if this shows or not, but my chin should be red, and I've got bunches of little red spots on my forehead.
Yes.
I'm 17 days into a skin peel with 5-fluorouracil. I think Ray's done it too. This is my 5th or 6th one because of all those years in the sun. And when I went to the dermatologist, he biopsied 3 things, and they were malignant, but they weren't melanomas. And that's a preventative so that you don't end up with these pictures over here 5 years later. So that's, you see a lot of that.
No, wait a minute. So that a skin peel, why would you do that?
It's a topical treatment that's put on, or diffusely on, in Bill's case, since he has so many actinic lesions that can become squamous cells or basal cells. But he gets this is like proactive ahead of time, so he's not being whittled on.
It peels off.
This is not for everybody. You know.
Yeah, this is a good dermatologist.
It's for people it's for blondes who went out working when they're 8.5 years old and got burned up and didn't get out of the sun until they were in medical school.
Back when Bill was a little kid, they actually walked around with aluminum foil, shining up in their face.
I really don't want to do a skin peel.
Oh, this is my 5th or 6th one. It's not a lot of fun. All right, this next one is an interesting question, and this is a complicated case here. But it illustrates several different concepts that we've been talking about in recent months in a situation that's pretty hard and isn't going to respond quite as well as things we have talked about previously. My brother is 45 years old, so he's young, and he's in perfect health. And he has just been diagnosed with a spindle cell sarcoma of his back that involves the rib. He was scheduled for surgery. Now, that surgery, if it involved a rib, would have been huge. They would have had to take out this lesion. I'm going to show you a picture of one. The ribs are under it, so they would have to resect the ribs. That would mean they would have to resect the lining of the pleura of the chest. Then you'd have a hole and the lung would be down there, right? So you'd have to have a plastic surgeon and a thoracic surgeon in the operating room who could then take a muscle flap and cover up that big hole, and it wouldn't have any bone in it, but they would have to be able to cover up that hole so that it wasn't sucking air. So this would have been a huge operation to operate on that, but that is the way it would be treated.
Wow.
You would treat that way unless something else happens, okay? He was scheduled for surgery, but the scan found the spot in his abdomen. So during you don't want to do that big operation if there's somewhere else, so that you have to do something different anyway. All right. And it was also sarcoma. So that means now the spindle cells, I'm going to talk about that in a minute. There are so many different types of sarcoma, and they're so hard to characterize. You always send them to the Mayo Clinic, or you send them somewhere. It takes weeks of different types of genetic testing and different types of stains to make sure that you've got the exact right type, because the way you treat it, if you have to treat it with chemotherapy, is entirely different between one type and another. So anyway, now the surgical oncologist, medical oncologist, and the radiation doctor, so he already has been to the tumor board, right?
Right.
Want him to have chemotherapy before they consider operating on him. Now here's the part. A few weeks ago, you discussed a similar man, same age, with rectum cancer and 2 liver spots. You remember that? Yeah, you remember, right? Who had the liver and the rectum cancer removed. Can this be done for my brother? Well, we like to do what we call proof of principle. If antibiotic treatment's good for dermatitis on the face, it's probably going to be good for dermatitis on the leg. That principle has been proven, so we'll broaden the concept. So that concept with the rectal cancer and the liver, there are so many colorectal cancers, as we showed you a few weeks ago. Most common cause of death now is colorectal cancer, since lungs go down and breast has gone down, and it's covered for both people. So we have tens of thousands of patients a year we can do experiments on here, right? You haven't got that many for sarcoma. the chemotherapy responds beautifully, colorectal cancer responds beautifully to chemotherapy, and quite frequently, you remember I said we bring the ripples back closer to the center, and this was easy. In sarcoma, they don't respond that well, but it's crystal clear that what these people are trying to accomplish for your brother is the same thing by giving chemotherapy, and that chemotherapy is going to depend on what the pathologists decide the exact type of these two sarcomas is. And the chemotherapy can be some that requires you to be in the hospital for 5 straight days and is big-time chemotherapy, or it can be like we give in the office in Blue Ridge. So let's go to that first one. So we're talking about soft tissue sarcomas. If you look at this, there's a blinking soft tissue sarcoma for every tissue type in the body. Over here, this is fat, so that's called a liposarcoma. That one's fibrous tissue like inside muscle, that's called a fibrosarcoma. Round cell sarcoma, peripheral nerve, leiomyosarcoma, smooth muscle. Well, I'm going to tell you that this is probably a spindle cell type of a muscle tumor called leiomyosarcoma. But if you look, there are 12 different types of sarcoma there, every one of which would be treated a different way. And when you get to osteosarcoma, you remember the Kennedy boy who had the chemotherapy and ended up having an amputation, and then a few years later, so it's about maybe 40, 35 years ago, and you see these Danny Thomas kids at St. Jude's, where they go up there and now they get chemotherapy infused into the leg to try and preserve that bone. I mean, that's one type of treatment, and that's a sarcoma. Okay, pull that one down. So this patient, this is Ray sees this in his office 4 or 5 times a month, and it's a lipoma. What you do is you turn the lights off in the room, you take a light and you put the light over here, and if it transilluminates light like water, then it's fat. But if you do that and it's dark, then that's not fat. So you got to go look into it. So you can pull that down. So
if that comes into your office, if you can see through it,
well,
if you turn the light.
It also has other features,
right?
But they're
softer,
very common.
Yeah,
right.
But this is not common.
Yeah.
The bump on the back is very common.
Yeah.
Now, it may even get somewhere else. If it's not that big, it could be a sebaceous cyst or something. But anyway, so that one right there is a leiomyosarcoma. Okay. Now, the other thing that you see, this is a little bit better. This is a picture because this shows you exactly what this is, and that is a muscle tumor in the calf muscle. Just has a better picture than the one in the back. And so instead of being fat or a cyst, that's actually a muscle tumor that's deforming the skin. All right, pull that down. What's this here? Algorithm. All right. So what I said was, right now, they're sending this tumor off to the Mayo Clinic or to the National Institutes of Health, and they're doing lots of very fancy, learned it at Georgia Tech, electron microscopy and different types of staining, because they've got low grades and high grades, right? Well, all these leiomyosarcomas aren't high grade, but he started right off by saying spindle cell. Of all the sarcomas in the world, so you remember the sarcomas aren't, you can pull that down a minute because we're going to talk about concept. When you saw that big circle a couple of weeks ago that had breast cancer as a big chunk, lung cancer as a big chunk, and colon cancer as a big chunk, that was most of the cancers, right? Well, that little bitty thing at the top that was about as big as a 2-degree, that was sarcomas. And then these tumors, this sarcoma is only 3% of sarcomas. Yeah. So it's fairly rare, fairly aggressive. And what type of sarcoma it is determines which type of chemo you get. And if it's an aggressive leiomyosarcoma, spindle cell type, the chemotherapy that this patient will receive, and if he's young and in good health, we know that, he will go in the hospital. He will be there from Monday morning till Sunday night. He'll get a continuous infusion of one drug. He'll get some other drugs during the week, and he'll require support to keep his white cells up and to keep his red cells up. And they'll treat him for 5 days, and then they'll watch what happens to him. And then 3 weeks later, they'll treat him for 5 days. So that's 6 weeks. At the end of 6 weeks, if that thing has shrunk down some, this is what he's got to look forward to. Put that next one.
I looked at that picture when you sent it over. I don't need to see it again.
Well, I mean, this is a big operation.
Yes, it is.
Yeah, and they're doing this to try and save the guy's life, right? Mm-hmm. So what they will do is you can pull that down. We don't make people look at it, but they are still going to go in. They're going to resect the ribs. They're going to resect the pleura underneath it. They're going to have to bring a flap up to cover it. And they're going to operate on the abdomen and remove that thing in the abdomen, which you don't know how much stuff they're going to have to take out. And then they're going to pray that they've beaten it back and that they've gotten it all.
Bill, when you have odd or rare cancers like this, how do you look for protocols or research centers that may be specifically treating that cell?
Great question. Yeah. Great question. I have a similar patient to this right now. Mm-hmm. I immediately send him to the Sarcoma and Melanoma Institute at Northside. Mm-hmm. So everything he does has to be done at the big Northside. And that's people who do absolutely nothing but this all day long. You remember when I talked about my hip replacement, the guy did 23 of them in one day? Mm-hmm. All he does is replace joints, focus his orthopedic only on that. These are people who have focused their surgical expertise, their chemotherapy, their immunotherapy, their radiotherapy, and everything else on melanoma, sarcoma, which are both aggressive, poorly, and are companion-like diseases. And that's where I would send the patient. I don't know where this patient's being treated, but it's got to be in a center like that because he's been to the tumor board. Because what he said was the surgical oncologist, medical oncologist, so he started out with surgical because on his back. Medical oncologist, because now he's going to need chemotherapy, and radiation doctor, because he'll end up having radiation to that spot in his back, I guarantee you, have collaborated on him. So he's probably at Emory, or if this came from Florida, he's at Moffitt or somewhere like that. He's in the right place.
One of the points I wanted to raise with this is, it's being connected to people who are themselves connected and are paying attention to all of this network capacity. But it's also one of the beauties of our healthcare system.
It is.
That we have such focused, research-centered entities that are spread around that patients can get to. Would never happen in a Canadian-style healthcare system.
No.
And it just wouldn't happen. You can't do this with the post office management system. Okay, and so every time somebody comes up with, well, let's just nationalize healthcare, they have no idea what they would be destroying to go there.
Hard work. Not political now. We're not talking about
political.
No,
we're not talking about politics. We're talking about medical
organization,
innovation,
and all those people in Canada are excellently trained.
Excellent training. I'm not putting them down at all.
No. It's just
those
system.
Cases come down here.
That's right. They come across the border. Anyway, that's good enough for that, right?
We'll take
you want me to show you the positivity rate this week?
You can show me the positivity rate.
Because we're going to go to the news here in just a second. Well, the positivity rate this week is 4.7% in Georgia, and I need you to tell me how many deaths there were this week.
Deaths this week
in Fannin County.
Or the total?
No, how many new deaths this week in Fannin County? What's the total number?
111.
Right. What was it last week? 111.
Okay. All right.
Okay, you remember the week you'd gotten confused. You were back to 107 last week. 111.
Yes, I did. Absolutely.
And what's the weekly rate for the last 2 weeks of deaths in Fannin County? 0.
Right.
Okay. Now, what's the case rate in Fannin County? Remember, we were red hot for a long time.
Yes.
The case rate is 6 a week for the last 2 weeks.
Okay.
All right, now the testing number went up from 1% to 4.7%, which doesn't bother you much, but it means there's more positive tests, but they must not be in Fannin County. Does that help you?
For the whole state.
For the whole state.
Comparing the whole state number to the local number.
Whole state number to the local number. So there you go.
Back to your solution is you've quit paying attention to these numbers because you don't trust them.
Well, okay, yes. I mean, it's not, okay. I don't know that
Well, I think that's common with lay people now. They've seen so many things thrown around and so many things that are confusing that by now they're just rolling their eyes at it.
It's who's giving me the information. And when I say that, I'm talking about America. Who's giving us the information is what when I say we, there's a lot that we don't trust. Now, I don't disregard the information like the positivity rate. I have my questions on that. I won't go into my feelings on it, but I have my questions. But I know the two of you study this throughout the week, and you know what's going on, and you're in touch with it. So I trust when you tell me things. So it's confusing to answer that. But when somebody comes out and they can't say the same thing day in and day out.
Are you trying to tell me that the public has lost faith in the
Information
spokesperson for the U.S. government, the physician who has assumed
That's
the
exactly
position?
what I'm trying to say.
Well, why don't you just say it?
Well, I mean, listen, I mean, I don't know. It's just like I watched this week. We have a variant, okay, that first of all on Monday
was going to kill the world.
No, yes, but on Monday, and this is fact, the president or Fauci could not pronunciate.
Yeah.
They had an N in there on Monday. So they started the week out telling you it was the Omicron. Now, how do you pronounce it?
Omicron.
Omicron.
It's a
right.
Greek letter.
I got it.
Alpha,
I
beta,
got it.
Alpha, beta.
But on Monday, even Fauci, there's record, could not pronounce this.
Yeah.
And Sunday on all the shows, by Monday, there was widespread panic, but the panic was in the media that it's feeding us stuff. Tuesday, they were calming the panic.
Okay.
Wednesday, they found a case.
Well, they had 5 cases as of this morning.
Right,
It's all over.
but now
you got to wait.
We're reading in South Africa that this might be related to a cold. I don't know.
Right. Well, COVID is a cold. Well, let Dr. Tidman tell you what the woman who discovered this thing, and is the president of we all say the president of the AMA. Okay, she's the president of the AMA for South Africa. Go, Ray.
And she's doing her job and reporting what she's finding, and the media and the hair on fire folks have just blown this thing completely out of proportion. And now she's back. She's not backing up. She's saying, "Look, I'm just reporting a mild form of COVID-19 that is in my community."
Say it again. Mild form.
Okay,
and
so
it's occurring in younger men.
People. Mild symptoms. Nobody's being hospitalized with it, and she's just doing her job of informing, which is what we didn't get out of China at the very beginning of this thing. So they take this, something new. Well, by the way, there's something new pretty much every day. Okay? Every day. They're finding variants every day. But they run with this one. So let's not
go on now. What'd she say about England?
Well, I mean, the thing is now they're shutting her country down. They're shutting travel down. They're all reacting to things.
And it all started with England.
Yeah. And the Brits are jumping on this, but
okay, I want to go one more place with this woman because this is what you don't hear from Fauci. Okay, so now she said, "I discovered this. She didn't discover it.
Yeah.
Her lab discovered it in one of her patients, but she is a big COVID treater."
Yeah.
And my observation in my practice, which she's allowed to say, is I've had many cases and nobody has been hospitalized, nobody has been terribly sick, and there have been no deaths. I will say, and this is what she says, this has been primarily in younger, healthy people, more males than females. And then she's very careful to say, I'm not sure exactly what would happen if an older person with comorbidities got it, but they haven't. And so far, it doesn't look like it's near as virulent as any of the other COVIDs that we have had. Now, that's her opinion, but immediately what happened in the world? England shut down travel. We imposed, the U.S. imposed a travel ban for South Africa. We imposed a ban for everybody coming in the United States. Even if you are vaccinated, you got to be tested before you get on the airplane to come in your own country with your own passport. So in the last 4 days, the world's gone crazy over this thing.
And it's worse than crazy. Okay, I
It is.
get
it.
This is where I want to get a really strong point here. Okay, and Bill and I have been saying this for almost 2 years now. Okay, any therapy. Well, we've been saying this for all of our career. If you're going to treat something, you have to know what the side effects are. Okay, what's the upside? And what's the downside? Okay, the downside. The economic studies from last year's shutdown is that over the last 20 years, we've had a very gentle, steady rise in the people coming out of poverty in the world. Less people going hungry. You don't hear about the hungry all the time. More and more people getting above subsistence living. Okay. Last year, they pushed, or the COVIDians, let me call them some nasty name.
Yeah.
Okay? The COVIDians pushed 100 million people into abject poverty worldwide. Poverty kills. Poverty kills. 100 million people pushed into abject poverty by these hairball, hair on fire. We got one hammer and everything's a nail.
Particularly places like India and
All right, well,
Africa.
let me ask you a question. All right, let me ask you a question. So, back when the majority, now years ago, September, that's Labor Day, right? Yeah, Labor Day weekend, right? Years ago, the majority of schools in this country started in September. All right, now there's different states starting August and year-round, whatever. But years ago, the majority of all schools started in September, and I'm going somewhere with this. Now, we don't have data because we don't record it. But if we had the data at that time, nationwide, colds go through the roof because the kids go back to school, they go like this, and they play with the same blocks, and the next thing you know, there's 9 kids in the kindergarten that have a cold, and they come home, and mom and dad have a terrible cold, and everybody in town has a cold.
Right.
Well,
for 3 weeks.
You are too old to remember. If you'll just go back to 1950 forward, what happened then was acute rheumatic fever, and because the kids all got strep throat, there wasn't any treatment for strep throat. The mama got strep throat, and she got rheumatic fever, and she could die from it.
Yes,
So
no.
Okay, so that's
No, I'm with you there.
All right.
But what I'm getting at is, so how many, if you got 25 kids in a class, one kid shows up, has a cold, he's rubbing, and he has a cold, what would you just say, how many in that class would probably end up with a cold?
Half, a third.
Right?
Yeah.
So we're hearing, is it called the transmittable,
Yeah.
excuse me, Justin,
Ours zero.
we're hearing the transmittable rate, right? Because every time they discover a variant and give it a name, the next thing they want to put the fear in us is the transmittable rate.
It was
This
1.7
this
for the
one
big
transmits 1-to-1.
It was
This
1.7
one was
for the
1 to
original,
6.
it was 6,
right?
yeah, that's
Yeah,
right.
Now
it's
you
called
just
a row number.
Now you're just telling me the common cold could take that classroom of 25 and maybe even go up to half, 50% walk out with a cold. Now we cannot, as when you said, let's go back to what you're telling me is you don't trust the person bringing me the information. I am not living in the fear of the unknown. And that's what they want us to do, is live in the fear of the unknown.
I agree.
Well, you're right. I mean, but my point to restate is that this therapy, this heavy-handed, shut down the world, treat some people like they're dirty, scare the heck out of everybody, give bad, incomplete information, is failed. Utterly failed. Needs to stop. Okay? This is now an endemic virus. It's in and around. It's morphing and changing. It
Yes.
requires
You
local
told us that a
therapies.
long time ago.
Requires local therapies, local physicians doing what needs to happen in their arena, in their area, and the government and the bureaucracies who want to treat everybody the same way and all be the heroes patting themselves on the back, who are net killing more people than they're helping, need to shut up and sit down. This is an endemic disease that physicians and healthcare systems are trained to take care of, and the White Castle folks who don't ever touch a patient have no clue of what they're doing, and they're harming more people than they're helping.
All right, now
Right here on a Friday. All right, go ahead.
I'm
Right
going to
here.
say, I agree 100% with what he said. Also emphasizing that fine china needs to be protected.
Got it.
They need to continue to protect their airspace. They need to continue to take the immunizations, because fine china is fine china, and they need to be protected. And we need to get on with our lives. And when you watch the ball game at 4 o'clock on Saturday, they're going to be 88,000 people crammed into the Georgia Dome, and they ain't going to be wearing masks. And I saw a thing on the TV last night of kids in San Francisco or somewhere that are still 6 feet apart, and they're 4 years old, and they got this mask halfway over their face, and it's just as ludicrous.
Or we have our president pull his mask down, sneeze into his hand, put his mask back on, then walk down and shake hands with people. Ludicrous. Okay? Ludicrous. Now let me finish.
Go
what I'm
ahead.
trying
No,
to say
go
here.
go ahead.
Okay?
No.
It's an endemic infection. It is varying and changing. Okay? And what I'm worried about, because I'm seeing it in myself, is you get exhausted with this. You get exhausted with explaining this. So what I'm telling my patients right now, okay, even my fine china, who've been vaccinated in 3 shots, you can still get the bug. Okay? I need you to call me. I need you to call me at a moment's notice if you think you've been in contact and you got the bug, because I can treat you. And I don't want to find out. I don't want to find out when you've got blue lips and you're on the way to the
and
ER.
plus now we got new things that have come out in the last week. You
Right.
could be able
Literally,
to use.
I can treat you. So stop fearing the thing. Be careful. Be smart about hand washing. Be smart about who you're around. If you're sick, stay at home. Don't go spreading your germs, even if it's just a cold. Okay?
Right. We
But-
didn't do that. We
Right.
normally didn't do that
Right.
before.
Right. So but I want my patients in this day and age to call me and let me aggressively treat them. And I want the people listening to this, I want you to ask your doctor, do they treat? And if they don't, get a new doctor. I'm sorry, get a new doctor. If your doctor says, oh, we don't, until you get in the hospital or until your oxygen levels are below 90, I don't have anything I can do for you. Okay, that's not acceptable.
You baloney, yeah.
Yeah,
We
not
can
acceptable.
get you the antibody. We
Yeah.
can get you all sorts
All
of stuff.
kinds of
Well,
things.
right here on this couch, and this is what I wanted to say here a minute ago. Right here on this couch, you have shared with this audience. Over now, we're into the 2nd year. You have shared that it's a variant that will change. It will mutate. We were going to have to continue to study this, stay on top of it, be ready for what it may do next, but not stop living.
That's right.
And now here in South Africa, they have found, to me, a cold, what is equal to a cold right now, and we have shut down air travel. We have done everything, and I don't want to go to the political side, but we can't keep putting these people. It's not healthy to live in fear.
It's not, and it's
It's
a
not
mass hysteria.
healthy.
I mean, it's like the movie Groundhog Day is a comedy. It's a comedy. Contagion's not a comedy. The movie Contagion, where you have some bug that goes around the world and kills everybody, and they keep running that thing like it's Groundhog Day. Whoever they are, it's not. It's not.
I'm going to
fun.
say
It's
this.
not-
This segment is called, and don't take it. This is called Ask the Doc.
Yeah.
With Georgia cancer specialist from Northside Cancer Center. So I'll leave this, and I want to say this because I have the two of you.
You got political coming up. You can ask that.
Myself included with many out there, until it's someone other than Anthony Fauci,
I'm not going to pin it all on him. I mean, there's a
I'm
lot
not
of people
pinning
involved
it
in
all.
this.
No, you're right. It can't be. But until there's another face in front talking to the American people, that's why when he says the positivity rate, and I say, yeah, I heard.
All right,
you know,
let me. You mentioned our sponsor.
Right.
Our sponsor does their excellence because of what Bill was talking about in these cancer therapy patients.
Absolutely.
They're individualized network care where you get what you need when you need it. Okay.
Exactly.
And that's the kind of excellence that we need pushed forward now. And all this other hysteria that's above us, it's just people looking to get their face on TV. We need to turn it off and ignore it.
Exactly. And one of the things on what you said, and I know we got to get out and we have some news. We'll stay and talk here. I've got a little extra time. But one of the things you just said, pinpointing that sponsor, is the concerns that we've had right here on the couch. And I personally have had concerns with, because he has said on this show how many times that you've met with patients that you said, man, I wish I'd have had you in here 3 months ago. I wish I'd had you.
Right.
And we actually had where these people needed to be involved in their health care, and they're in a bad place today because of something that put them in fear of going to the doctor. You know what I mean?
Got it. Yeah.
So, all right, well, you got any news?
Well,
or did we just cover?
no, because we were.
You got anything to say?
Yeah, well, wait a minute
But
now.
let Bill finish.
Wait a minute now, because there's stuff
No,
there's stuff in here that I think you should just throw out. Like Ray and I were talking about a couple of weeks ago. The thing came out, and we mentioned it here, that people didn't know whether the aspirin was good or wasn't good if you had heart disease, and maybe it was. I said, well, look, the thing has other good effects, like it can decrease colon polyps, and if you and your doctor have decided a baby aspirin is good for you, keep on taking it until you and your doctor decide you don't want to take it anymore. But look at this, came out yesterday. Daily aspirin linked to an increased risk of heart failure. I mean, that's BS, and people just love having.
Wait a minute. You told me to take my daily aspirin.
I did, so that's why I'm trying to tell you to keep taking it too.
That's why you don't let the internet treat you.
That's right. You don't go to Dr. Google. Now I showed
You've had
you
me
this.
on a daily aspirin
understand
every
that,
single morning for
But
how
I had
long
you,
now?
I had you read this thing, this one here, because you had showed a TV thing, and
Yeah.
read that one out loud.
Transgender docs warn about gender affirmative care
For you.
for youth.
Okay, the only thing I want, and I had already chosen this before you showed that, and that is that there is a group, an international group of physicians who are dedicated to the medical care of transgender patients. Okay? I happen to be involved in 1965 with Dr. Robert Greenblatt, who invented the birth control pill, in the very earliest things of transgenderism. And so there's been a whole bunch of progress since 1964 and 5. But there is a transgender population, okay? And we just going to have to accept the fact that there is. The transgender medical community that takes care of this is absolutely against what you just talked about in the Chicago schools. It is their belief that young children who start talking about, I like to go to the girls' bathroom, boys' bathroom, or whatever it is, should be in the hands of medical professionals, psychological evaluations, and so forth, because many of them may have chosen this because it's going to be cool, or they're rejected by their friends and group, and maybe I'll be better off over here, and they go down a pathway that too many physicians are supporting by giving bureaucrats by doing this, and them by telling their parents, well, you need to let them do what they want to do, and even starting hormonal therapy on them when they're 10. The transgender medical community does not believe in blocking puberty with drugs, giving pre-adolescent kids gender-changing medication, and a lot of this stuff you're talking about there is doing it, and it's wrong, because these kids, when they finally become emotionally mature, and when you become emotionally mature, I mean, you could say 18 you can vote, and 21 you can, 18, yeah, 21 you can drink, but real emotional maturity is in your mid and late 20s. So many people that's been shown that have started down this pathway are just greatly regretting it in their 20s because they made an error. But you can't go backwards.
And let me polish that just a little bit. Any transgender, any sexual change or difference from the norm is a very complex, very personal issue. And it has no business being treated as a political entity. No business. I mean, this is something where families are struggling and praying and working with hopefully good professionals. And this should not be drug out in PTA meetings or in school boards or in state capitals. This is a very individual, complex thing that we don't really have good answers for. So, once again, let the politicians get the heck out of this. Making this the cause celebrity right now is damaging, damaging way more people than it's helping.
There you go. That's what and that's not Ray Tidman talking.
Yeah.
That is the transgender medical community that knows what they're doing.
Right. And
They know what they're doing.
Intense therapy.
All right, that's enough.
Don't you have to go to work?
I'm
Are
20
you
minutes
late for work?
Yeah, I am.
I got a joke
You got
for Joe,
Joe?
though.
You got
Okay,
Joe?
go.
You've been playing golf lately. A couple of times I've heard about you on the course.
Well, yeah, but it ain't often.
But you know why golfers now wear 2 pairs of pants?
No.
You might get a hole in one.
Oh, that's a good one. Well, thank you.
We're going to go to break. I don't know what I'm
Thank you,
supposed-
Northside Cancer
Yes.
Center, for supporting
Georgia,
this time.
wait a minute. Thank you, Georgia Cancer Specialist, Northside Cancer Center, and whatever you do, don't send people to the Georgia Dome Saturday. You said they're going to the Georgia Dome's not there anymore.
Oh, yeah, what is it? So,
The Mercedes-Benz.
Mercedes-Benz Stadium.
You're going down to the Georgia Dome. I would be going to. So anyhow, thank you. Ask the Doc William Whaley and Dr. Raymond Tidman. We'll take a break and we'll be right back.